resistance of the insulin, there is rise of insulin level in the blood, and this rise of increased level in the blood causes stimulation of the pituitary gland, where from LH. In my knowledge and my practical knowledge, the polycystic ovary is to be labeled a patient, female patient of reproductive age when there is a presence of small cyst about 10 millimeter or more and numbering more than 10 in both the ovaries, number one. Number two, there is increased level of androgen in the blood. The patient may have hirsutism and period of infrequent period, and sometimes they are coming for infertility with the presence of the complaint of infertility. And how to whom we will label that she has been suffering from polycystic ovarian disease. Among these 3-4 criteria, presence of 2 criteria like small cyst, polycystic ovary, and hirsutism or androgen are at least 2 criteria among this having these 2 criteria, the patient can be labeled as polycystic ovary. The maximum, why the polycystic ovary is now a subject of concern, because there are so many patients, that is about 8% of patients of reproductive age suffering from polycystic ovary. In our clinic, every day we see 1 or 2 polycystic ovary, and some of the young girls, they are coming with the complaint of infrequent period and hirsutism, and some only comes for infrequent period, and some of the patient comes for infertility. Some patients come for acne vulgaris or plain acne, but on ultrasonography it is found that there is a polycystic ovary. At the same time, if we test the androgen level in the blood, it may or may not be increased. It may or may not be increased. We are very rarely find increased androgen. But now the question of treatment concern, and it varies from, it depends on the sub factors, whether there is increased level of androgen or not, so there is hirsutism or not, there is infertility or not. So main thing is that how this polycystic ovary occurs, nobody knows. But we have seen some criteria, that is we find that there is increased level of the insulin in polycystic ovary due to the insulin resistance. Due to increased resistance of the insulin, there is rise of insulin level in the blood, and this rise of increased level in the blood causes stimulation of the pituitary gland, where from LH secretion starts and it increases in the blood. And this LH goes to the ovary and it causes an evolution and abnormal secretion of the androgen due to the stimulation of the enzyme which are responsible for the secretion of the androgen. And this is the, in nutshell, the main pathophysiological features in a polycystic ovarian disease. But when we go for the treatment, we have seen that the pharmaceutical companies are introducing the medicine which contains minocytal and decardiocytal in 40:1 ratio. These myocytal and decardiocytal are present in our body in a physiological level, and there is an alteration in this level for which somebody thought that this may be the alteration of the myocytal and decardiocytal ratio alteration is responsible for polycystic ovarian disease. And the treatment is now become very easy because of the invention of the pharmaceutical industry. It's like the medicine like Namuro, which contains minocytal and decardiocytal, and to regularize the cycle, containing the ethyl estriol, and there is many preparations in the market like Fertilab, like Figures 30 and Crimson 35 and so on. These regularize the cycle, and it also have some good effect on the acne. After using this, the acne becomes lesser intensity. And is also, after the controlling of the cycle, we will, along with this regular cycle regularizing that, we also give minocytal and decardiocytal to stabilize the physiological level of this decardiocytal and minocytal. And after the regularization, the patient usually gets relief for temporary period, some period, but it reverts again because we do not know the actual pathology. Therefore, so it comes again. Repeated treatment is necessary to give the relief of patient.